Hi everybody, today we will discuss keratoconus management. By definition, keratoconus is a progressive, non-inflammatory, bilateral, but usually asymmetric ectatic corneal disease. It is characterized by paraxial stromal thinning and weakening that lead to corneal surface distortion and conical shape of the cornea. Etiology. Mean etiology of keratoconus is unknown, but in some cases there is a positive family history. Also, recurrent corneal trauma due to chronic eye rubbing can lead to corneal weakness and corneal ectasia, like in cases of blepharitis and vernal keratoconjunctivitis. Pathology. Pathology of keratoconus include epithelial basement membrane fragmentation and scarring, like here. Axial stromal thinning and scarring due to weakening in the corneal collagen bundles, which leads to dehiscence of the collagen fibrils from each other, and this make the thinning occur. This overstretching of the cornea will lead to breaks and folds in the basement membrane, leading to formation of what is called corneal striae in the basement membrane. If break occur in the disc membrane, this will lead to influx of aqueous to inside the corneal stroma and causing what is called acute hydrops. Clinically, patients with keratoconus often report decreasing in vision with bad vision quality due to distortions, glare, monoocular diplopia, and ghost images. Also, early in keratoconus, patients complain of multiple unsatisfactory attempts in obtaining optimum spectacle correction. Usually, the patient of keratoconus will need to change his glasses many times at 1 year in a frequent period of time. This occurs in early cases of keratoconus. Sign. The main sign in keratoconus is decrease in the visual acuity due to progressive myopia due to increase the corneal curvature and irregular astigmatism. By ophthalmoscopy, we can see oil droplet sign as in this photo due to the presence of the cone through the light of the direct ophthalmoscopy, which causes red reflex in the iris bevel. The presence of the cone make a reflection called oil droplet sign. One of the important signs also by retinoscopy is called regular scissoring in this photo, like this photo. When the light line of the retinoscopy passes through the cone, scissoring of the line of the light will occur. Other slit lamp findings include Fleischer ring, like here, which is a line of the position of iron at the base of the cone. The second slit lamp finding is Vogtstria, which are lines of stretch marks present in the distant membrane forming vertical lines and can be seen by slit lamp. Other signs which can be seen by slit lamp include stromal thinning, stromal scarring, and enlarged corneal nerves, and lastly we can see acute hydrops in acute cases of a break or a tear in this membrane. This will lead to influx of aqueous to inside the corneal stroma and fluid accumulation inside the cornea with blepharospasm, photophobia, and sudden acute decrease in vision. This condition usually ends with healing by corneal opacification. Manson sign is a V-shaped indentation observed in the lower lid when patient's gaze is directed downwards, like this photo. Heal acute hydrops. When acute hydrops healed, usually healing ends by corneal opacification, like this photo. Investigations. There are old methods for detection of keratoconus, which done by placido disc and retinoscopy. placid disc like this photo, which are circles of reflected light on the surface of the cornea, and here we can see that these rings or circles are not regular. It's like spiral in shape, which means that the corneal surface is not regular surface. New methods today or nowadays which we use to diagnose keratoconus include corneal topography, which evaluates the anterior corneal surface, and Pentacam or Scheimpflug based devices, which evaluate the anterior surface of the cornea and posterior surface of the cornea. What Pentacam or Scheimpflug based devices says to us? It evaluates the corneal thickness by what's called pachymetry map, corneal curvature was called keratometry map, cone site and shape, elevation maps, which include anterior elevation and posterior elevation, and provisional diagnosis by some devices like Sears device, a biometry map, which can be measured by this device, but here is the abiometry of the cornea only, not eye abiometry, only corneal abiometry. And lastly, Scheimpflug imaging, which evaluates the anterior segment, including the cornea, anterior chamber, and part of the anterior lens. This photo of Keratoconus summary of print out of some of Sears device, and we can see that there is the accentuation of the problem, which is presented in the form of red light, like here, and the device here give us a diagnosis called suspect keratoconus. This is Scheimpflug imaging of the anterior segment, and here we can see the cornea, and even there is a blunted intracorneal ring segment. We can see here is the iris and here is the angle of the anterior chamber. Classification of keratoconus. Several classifications of keratoconus can be used. They are based on whether morphological patterns or topographical patterns. Morphological pattern. There are three morphological patterns of keratoconus according to shape of the cone. The first include nipple cone, oval cone, and globus cone. This photo shows nipple cone, which here the cone in the center of the cornea and with a small area. This photo shows an oval cone. Here the cone in the center and extends downwards and larger in size than nipple cone. Lastly, globus cone, in which the most of the cornea is ectatic, and here the cone involves a large area of the corneal surface, like this photo. Topographical patterns. Classification which depend on topographical pattern. The most important one of them is called chromic classification of keratoconus, which depend on the severity of keratoconus. It is called also amsler chromic classification. This classification depends on mean keratometry readings on the anterior curvature sagittal map, thickness at the thinnest location, and refractive error observation. In this table, we can see that keratoconus is classified into 4 stages: stage 1, 2, 3, and 4, where every stage includes the size, the shape of the cone, the degree of refractive error, and the presence of other slit lamp finding, like here Vogelstar in stage 1. Stage 2, we can notice that the corneal curvature increased, but there is no corneal opacity. In stage 4, there is corneal scar and very thin cornea, together with inability to measure the refractive power of the eye. There is a new staging system of keratoconus, which is called Bellin ABCD keratoconus staging. It is a new keratoconus staging system that uses current tomographic data and better describes the anatomical and functional changes seen in keratoconus. This staging system includes the anterior and posterior curvature, thinnest pachymetry values, and distant visual acuity, which measured by the physician. And its stages include 0 to 4 means that it includes 5 stages. This is an example of an normal case. We can see that A, anterior radius of curvature, posterior radius of curvature, thin stoichiometry, and here we should put the distant corrected visual acuity to give us the staging. While here it is a keratoconic eye, we can see that the A and B and C means that there is a problem in the cornea, and we also here we should put the best corrected distant visual acuity. Forme keratoconus. It is a subclinical disease and is not a variant of keratoconus. Also, clinicians use many other terms such as mild keratoconus, early keratoconus, and subclinical keratoconus. Recently, there are two opinions regarding the definition of this disease. Forme keratoconus is a completely normal cornea with neither clinical or topographic risk factors, but this cornea is able to develop keratoconus when treated by laser. So we should know that this disease is important for us to protect the patient from developing post-laser corneal surgery ectasia. So when the cornea is suspicious, it is called forme keratoconus. The fellow eye of this forme eye may be keratoconic, or there is a positive family history of keratoconus. Also, we can treat forme keratoconus like an abnormal cornea, corneal topography, or corneal hysteresis, or both are abnormal. There are risk factors, but the case is still not a clinically obvious keratoconus. In this photo, corneal tomography printout, we can notice here that there is high posterior back elevations with thin cornea, the corneal thickness about 489. This cornea is a suspicious cornea and not straightforward cornea. This differential map of this Pentacam, we can see that there is accentuated back elevations and accentuation barometric thinning, which means that this cornea is abnormal. Another photo of corneal topography. Here the thickness is well and good, about 591 micron, but however the back elevation is high, about 14. In the keratoconus semi or differential map of this cornea, we can see that the problem of back elevation is more accentuated, which means that this cornea is suspicious. Another topic of non-inflammatory corneal ectasia called pellucid marginal degeneration. It is a bilateral non-inflammatory peripheral corneal thinning disorder. It is characterized by a peripheral band of thinning of inferior cornea. The cornea in and adjacent to the thinned area is ectatic. Patients usually are of middle age, from 20 to 40, not like keratoconus in which most of patients are teenage. The most characteristic sign in this disease is what is called butterfly sign or crab claw sign, which is caused by flattening of the vertical meridian with steepening of the horizontal meridian with peripheral corneal thinning with back elevation and front elevation. Keratoglobus, as we mentioned, it is a form of non-inflammatory corneal ectasia where the cone involves most of the cornea. Most of the cornea is ectatic, like in this photo. Options for treatment of keratoconus. There are many options for treating keratoconus. Options depend on age, refraction, pachymetry, keratometry, cone position, and corneal opacifications. Options for treatment include glasses and follow-up, hard contact lens, cross-linking by its types, transepithelial or Epi-off cross-linking, intracorneal rings including Kira rings or Mayo ring, and lastly keratoplasty including lamellar or penetrating keratoplasty. Rules in treatment of keratoconus. None of treatment option mentioned before is satisfactory for the patient. Usually patient is complaining even after treatment. The disease is progressive by its nature. Follow-up of these cases is mandatory and essential to avoid any progression. Combination of treatment options can be done as cross-linking with intracorneal rings, for example. Keratoplasty usually can be considered as a final destiny, even with treatment. Rings mostly will be followed by glasses. Don't judge on improvement of visual acuity without correction. And lastly, financial aspects should be taken into consideration. Usually the treatment of keratoconus is expensive and need many lines of therapy, and all of them costs me a lot of money. The first line include glasses and follow-up. When to do that? If the patient age is more than 20 years old, as in this age the keratoconus become more stable. In the stable cases with low refraction with best corrected visual acuity more than 6/24. In cases of clear cornea. In cases of early stages of keratoconus with favorable Pentacam, in cases of average keratometry less than 46 diopter and sinus stoichiometry not less than 480 micron. Hard contact lens. Gas permeable lenses are not the same as all the hard lenses. For one thing, that gas permeable lens material allow oxygen to pass through the lens and reach the cornea. With advances in manufacturing, gas permeable lenses are made in a thinner design, larger diameters, and with more consistently smooth edges than ever before. Gas permeable contact lenses are custom made for each individual. Parameters which are needed for gas permeable contact lens request, including keratometry, which is needed for initial fitting, and refraction. In this photo, we can see the hard contact lens or RGB lens, which is fitted to surface the cornea. We can notice that it does not include all the cornea surface, but only the center of the cornea, mainly over the cone. Soft lens is more tolerable by the patient because it gives initial comfort, while gas permeable lens require a brief adaptation period because of the size of the lens. Soft lenses are larger in diameter, so it is tucked under the eyelid, while the RGB lenses are smaller, and during blinking the patient can feel it. So another advancement in manufacturing of this lens called hybrid lens, or what's called mixed lenses. These mixed contact lenses it include a combination that has an RGB center surrounded by a soft peripheral skirt. So we can use the effect of RGB lens in the center in the optical zone, while peripherally it is a soft component which can be tolerated by the patient. As in this photo, we can notice that the peripheral is soft while the center is hard. Corneal collagen cross-linking by its type, transepithelial without removing of the epithelium, or Epi-off with removal of the epithelium. Why cross-linking is important? Corneal collagen cross-linking is the only actual therapy for keratoconus. Its main effect by stiffening and flattening by creating a reaction between collagen bundles and riboflavin and ultraviolet rays. In the presence of ultraviolet rays with soaked collagen fibers with riboflavin, cross-linking bundles is initiated between the corneal collagen fibers and more stiffening of the cornea. So its effect is long-term effect with minimal optical effect. Transepithelial corneal collagen cross-linking. Important hints: It is less effective than Epi-off cross-linking, less flattening effect, less complication rate, and more comfortable for the patient. When to do? We do that in cases of early keratoconus in middle-aged patients with very thin cornea in which we can't use Epi-off technique, and after intracorneal ring segment implantation, and in patients with inadequate follow-up for epithelial healing. As in this patient, we can notice that corneal thickness is good and not a frank case of keratoconus. We can do for this transepithelial cross-linking. Epi-off cross-linking, which includes the removal of the epithelium before sucking of the cornea by riboflavin. When to do in moderate and advanced cases of keratoconus and in younger patients less than 25 years old. In this video, we can see the corneal collagen cross-linking operation. Intracorneal rings. Goals of rings for keratoconus. It improves the uncorrected visual acuity, best to correct visual acuity, decrease the high order aberrations, and increase contact lens tolerance. So all of these will delay the need for corneal transplantation. What can be expected from intracorneal rings? The first, we should expect that intracorneal rings will cause corneal flattening, which decreases the spherical equivalent and in decreasing the slender with corneal flattening. Types of intracorneal ring segment, it include intact like here, and Kira ring like here, or what's called Ferrari ring, and lastly continuous one ring which is called Mayo ring. Ideal patient for rings in cases of patients with high error, with steep cornea, with high maximum keratometry, and poor visual acuity, with high patient motivation. There are different types of intracorneal rings. Kira ring, mostly used in cases of non-central cones with high cylinder and thickness at insertion site more than 400 micron. In this video, we can see the operation of intracorneal ring segment implantation by femtosecond laser. We apply the suction ring for femtosecond laser ablation process. Here, the stage of docking by flattening of the corneal surface, which is called ablination. This full ablination will followed by creation of the tunnel by femtosecond laser. And lastly, we will open this tunnel initially by opening the incision site. Then we try to widening the tunnel created by femtosecond laser before we implanted the intracorneal ring segment. We implant here the first ring by inserting it by a special device. Then we push the remaining part of the ring through the tunnel and then insert the other ring segments to the other side of the tunnel. We push the other ring by pusher. Then we apply contact lens as a therapeutic contact lens for 24 hours to allow healing of the incision site. In this photo, we can see the effect of curing pre and post curing. We can notice that there is a strong flattening effect. Here, the keratometry at 58, we can notice here that it is 53 diopter. My ring, it is a one complete ring. It is used mainly in central cones with high readings and high errors, especially in high myopic error. Thinnest location should be more than 4 micron at time of surgery. We can use Epi-off cross-linking here by injecting riboflavin through the pocket, and we can blunt it in eye without refraction. In this photo, we can see the effect of my ring before and after. Here, the keratometry is 51.7, and here we can notice that there is extreme flattening that the center here, the keratometry is about 43.9 and 45.4. Combined cross-linking with rings. We can combine the intracorneal ring segment effect together with corneal collagen cross-linking, whether in the same session or in another separate session. When to do with my ring, it should be done in the same session as we mentioned in the intra-pocket cross-linking. While with Kira ring, we can do it in the same session or after ring implantation. Age as a guideline for a decision of treatment of keratoconus. Younger age group, we should be more aggressive. In younger age group, keratoconus is progressive. So, in early keratoconus, we should do Epi-off cross-linking with follow-up. In moderate and severe keratoconus, we can do cross-linking and intracorneal rings implantation. While in advanced opacified cornea, we can do keratoplasty. In cases of middle-aged patient, more than 25, we can be less aggressive in treatment. So, in cases of middle-aged, early keratoconus, we can do Epi-on cross-linking or even follow-up without intervention. In moderate and severe cases, we can do rings only and follow-up. If there is a progression, we can do stabilization by corneal collagen cross-linking. And lastly, in cases of advanced opacified cornea, we can do keratoplasty. Home message at the end of this presentation. Many guidelines affect our decision in keratoconus management. Pentacam is an important tool in evaluation of keratoconus patients. Age is a guiding factor in treatment with aggressive attitude in young Asian. Customization should be done for every patient in keratoconus management. Thank you, and I hope you enjoy my presentation. Thank you very much.